welcome to this One Welbeck seminar. This will focus on diabetes and cardiovascular disease, although we're going to mention SGLT2 inhibitors that are some of my favorite drugs at the moment. Shivani knows many other drugs that we'll be talking about, and we'll be trying to cure both diabetes and the heart all in one session today. So who are we? Hopefully all of you know that we've been around for about a year now. So One Welbeck Gastro was probably the first off the blocks in orthopedics and cardiology. Endocrine has now joined, and Shivani is as one of the group. Both she and I work at Imperial College as well. So the way we're going to run it is there's going to be an intro from me, then we'll hand over to Shivani to tell us how to manage diabetes, and then we'll talk about some cardiovascular risk reduction. And perhaps the most interesting part of it will be 3 real life cases that we've had to sort out to see whether you agree with what we did. So the great news is that the practice is entirely COVID-free, and we'd like to stay that way. So we don't want to dress like that in One Welbeck. So I'd be grateful if the patient definitely has COVID, that you wait for them to get better before you send them to us. But if they have long COVID, then of course you can. And if they don't have COVID, more than welcome. I'm going to hand over to Shivani to take over and give us some diabetes news.
Hey, thank you. Hopefully you can see my slides. Okay, so hi everyone. Thank you so much for the introduction, Iqbal. And in the next 15 minutes, I'm going to just rattle through some of the things that I think are important to know about in type 2 diabetes. And you'll have to forgive me because I have gone back to basics, but I think type 2 diabetes is just so fascinating that hopefully you'll see why I'm going through the basics again. So why am I excited by type 2 diabetes? Because I think probably, in the exception being oncology, there's been diabetes is one of the specialties that's had a complete explosion of drugs in the last 10 years. And this is a timeline that I've stolen from somewhere else, which just shows that up until about 2006, we really had quite old drugs and insulin in our repertoire. Sulfonylureas were discovered in the 1940s, and so was metformin. And after that, we didn't really have much on the scene apart from pioglitazone and rosiglitazone, both of which have gone out of fashion, and the meglitinides. And then in that 10-year window, we've had this explosion of other drugs, which are listed here, so you know all of them. And there's been a huge drive from industry to discover newer therapies, so it's a really exciting place to work in. Now, as a diabetologist, I said I was going to go back to basics, and I just want to show you the evolution of type 2 diabetes because it is a progressive disease. And this is a cartoon which basically shows that by the time someone is diagnosed with diabetes over here on the right-hand side, they've already lost a considerable amount of their beta cell function. And the inverse of that is that they obviously have hyperglycemia, but also their insulin production is reducing by the time they get to see any of us. And we can see this from the UK PDS study, which is a graph here with time on the x-axis and beta cell function or a measure of insulin production on the y-axis. And the point that's being made here is that by the time we see people with type 2 diabetes and initiate their treatment, they've already lost about 50% of their pancreatic function. And if you extrapolate this line out a few more years, what you'll see is this pancreatic function, this insulin production is actually eventually going to go down to zero or close to zero, as we know it does in long duration type 2 diabetes. And if we add some drugs onto this drug chart, so metformin and sulfonylureas, good old fashioned type 2 diabetes drugs, what you can see is that despite what treatment you give, whether it's diet or metformin or sulfonylurea, again, old data now taken from UK PDS, there is this inexorable progression of beta cell function loss for reasons we don't quite understand. Although now, of course, there are programs to push people into remission, but still type 2 diabetes progresses. And if we look, this again is an old graph because we obviously don't use chlorpropamide anymore. But if you look at what happens to HbA1c in those years, it's the same thing. So there will be a reduction, but year on year, there is a gradual increase in HbA1c again. And this progressive nature involves that decline in beta cell function with poor insulin sensitivity. So this is something a lot of people forget, but I think it's beautiful physiology. So if we look at how sensitive a person is to insulin here on the x-axis and how much insulin they produce on the y-axis, actually there isn't a linear relationship here. So when we see people who are very insulin resistant, they're already producing a lot of insulin to overcome that insulin resistance. And the problem in type 2 diabetes is rather than climbing up this curve to meet maximal insulin production, they fall off this curve. So they already have an insulin production deficit. And that's really important to get into our minds when we think about different therapies. Now, I don't need to remind you, but just to say that the link between HbA1c and the development of microvascular complications on the left and macrovascular complications on the right, is a clear, there's a clear relationship here. And this graph on the left, this is how we've come up with our cutoff of 6.5 or 48, because that's when there's a takeoff in the risk of complications. But it's worth remembering that even people with low HbA1cs are still at risk. This is not this microvascular, the MI curve here and the microvascular curve here is not zero, even at an HbA1c of 6.5%. So where are we with NICE guidelines? And I'm afraid NICE guidelines, which were last updated in 2015 and are currently being updated, so we will have updated information. NICE guidelines are basically use anything that you would like after metformin. And we can't really blame NICE because in 2015, when the NICE guidelines were published, up until then, there had been a real sort of desert of cardiovascular outcome trials with absolutely no benefit from SAVOR-TIMI, which looked at a DPP-4 inhibitor, Examine, and also TCOS, and Elixir, which was lixisenatide, which was a bit disappointing. That also didn't have any cardiovascular risk benefit. And EMPA-REG was the sort of first outcome trial. Well, actually, it was the dapagliflozin one first, but it was really not much going on up until that point. So I want to just run through some of the considerations that I take around choice of glucose-lowering therapy after metformin, the background to SGLT2 inhibitors, and the glucose-lowering effects of SGLT2 inhibitors. So one of the first things that I look at when thinking about which therapy to initiate is the context. So the vast majority of people with type 2 diabetes fall into this left-hand box, which I've called incidental. It might not be incidental. You might have done the bloods because you suspected type 2 diabetes, but they're not clinically acutely unwell. They're not necessarily profoundly osmotic. And by osmotic, I mean excessive thirst, excessive urination, blurred vision, weight loss. And you've got an HbA1c which isn't off the scale. And in contrast, these acute presentations are on the right, and these are not always people who are ketotic or extremely hyperglycemic, but they do have evidence of osmotic symptoms. And many of the referrals that I get are people with HbA1cs over 100. So I'm sure that out in general practice, you're seeing a lot of these. And I'm not going to spend a lot of time talking about this right-hand box, except to say that in the presence of being very osmotic with weight loss and a very high HbA1c, my personal opinion is that this person will need insulin. So in the next few slides, I'd just like to run through the sorts of things that I'm considering when deciding on treatment choice. And this is sort of second-line therapies after metformin. And I've listed them here. So body mass index, age, comorbidities, frailty, the duration of the diabetes, and side effects. So let's go through some of these, and do stop me if you want to discuss anything that I'm saying. So for body mass index, I find this one quite straightforward. The NICE guidelines are clear. So if you have a BMI above 35 or above 28 if you're Asian, and also it can be below 35 if you have significant weight-related issues, you are eligible for a GLP-1 agonist, which is by far the most effective weight reduction agent in the context of diabetes. But the other thing that I want to say about BMI is to think really about the lean patient with type 2 diabetes, because in my opinion, a lean patient with type 2 diabetes is a bit of a red flag for thinking about whether it genuinely is type 2 diabetes, or whether it could be type 1 diabetes or a genetic form of diabetes. And thinking back to that curve that I showed you, with the relationship between insulin sensitivity and insulin production, if someone's quite lean, we would expect them to be quite sensitive to insulin. So then if someone's presenting with diabetes, why is that? Is there actually evidence of insulin deficiency? And as per NICE guidelines, certainly if you're seeing someone over the age of 50 who's quite lean presenting with type 2 diabetes, we should also think about whether there's a pancreatic malignancy. What about frailty? Some of you may have come across this lovely publication, which is endorsed by the NHS Diabetes Programme. And it's really some guidelines about de-escalating therapy of type 2 diabetes in frail individuals. So this is not age-based, but this is about frailty. And if you're interested in this, please do look up this reference, because it goes through an algorithm to define frailty. But the premise of this is really that as one becomes frail, or as one ages, the risks of hypoglycemia outweigh the benefits of tight glycemic control. And actually, there's good evidence to show that if you're diagnosed with type 2 diabetes beyond the age of 70, perhaps from all of the statins and the ACE inhibitors that you're started on, you actually have a survival benefit over people that don't have type 2 diabetes. So there's a lot that we don't know about very late onset presentations of type 2. And we should be thinking about de-escalating treatment, and we should also be thinking about side effects of our treatment choices. So for example, starting an SGLT2 inhibitor with a risk of a urinary tract infection, or having someone on quite a high dose of sulfonylurea in the context of renal impairment and provoking hypoglycemia. Diabetes duration is also something that plays on my mind a lot, and it might be because I'm based in secondary care. So by the time I get to see people, they've often had type 2 diabetes for at least a decade, if not longer. And by showing you this graph, again, just reminding you that if we extrapolate this line out long enough, we are going to see people who gradually become insulin deficient. And every now and again, we do see elderly people coming in diabetic ketoacidosis because their insulin has been stopped, or they've been unwell and they've developed an infection, and that's precipitated DKA. So when I see someone who has a suboptimal HbA1c, we can discuss what level that would be, and I see that they've had type 2 diabetes for 15 or 20 years, I'm wondering where they are on this curve and whether there's anything to gain by adding in a fourth agent or a third agent, and whether or not we should actually be escalating to insulin therapy. And just to remind you, it takes at least 3 years in some studies to actually bypass this treatment inertia that we have of seeing an HbA1c being higher than we'd like, but failing to address that with escalation of therapy. And I think there's a good study that shows that can take up to 3 years. Speaking of long duration, it's worth just thinking that we are all increasingly seeing more adults diagnosed with type 2 diabetes under the age of 40. Now, the caveat here is that under the age of 40, you are statistically more likely to have a different type of diabetes, such as type 1 or a genetic form. But as the population gets more obese, type 2 diabetes is actually increasingly presenting at young age. And this is really bad news because I'm not sure if everyone's aware of this, but compared to later onset type 2 diabetes and without diabetes, you actually die about 10 years earlier if you're diagnosed under the age of 40. more likely to have heart attacks and strokes, more likely to have microvascular complications, and worse outcomes from COVID-19 in data that's just been published. So this is an extremely high-risk group of individuals that if you have anyone in this age group and you're confident that the diagnosis is type 2 and not type 1 or genetic, we should really be hitting hard this group with aggressive HbA1c reduction and aggressive risk factor management. The other thing to consider are the side effect profiles of the drugs. And of course, this is not an exhaustive list, but again, when I'm seeing older people, I'm wondering if the degree of weight loss that's going to be induced by a GLP-1 agent is acceptable to the individual. Thinking about the frail individual with comorbidities and the risk of urinary tract infections, is that going to be acceptable? We've spoken about hypoglycemia and also dose adjustments and whether things need to be stopped in the context of renal impairment. Now, I've stolen this. A good colleague of mine, Kevin Fernando in Scotland, produced this really nice table, which shows, and you can get it from GP Notebook shortcuts, but it shows very nicely when you can and can't initiate. I'm just pointing to the SGLT2 inhibitors down here. So at the moment, the guidelines, the BNF still says not to initiate under an EGFR of 60. But if they're already on it, you can continue it down to an EGFR of 45. This is a lovely graph, and you do look at it later when you're looking back at the slides, but it shows the risk of hypoglycemia for all these different agents. And of course, the sulfonylureas we know have a very high relative risk, but a lot of that is in elderly patients and in the context of renal impairment. And the only agents that really come out quite neutral are the DPP4 inhibitors, and that's because they're actually, in my opinion, pretty useless at lowering HbA1c, so they look quite neutral. But otherwise, most of them are as much of a muchness in terms of risk of hypoglycemia. So what I've run through there is some filtering steps to really think about the individual in front of you. And where were we at before SGLT2 inhibitors, which Iqbal's going to talk about? We literally had nothing. So from all these big studies, Advance, UK PDS Accord, and there was no real improvement on the cardiovascular front. I'd also just like to highlight that sulfonylureas often get bad press in terms of cardiovascular outcomes, but you can see that the newer ones like glimepiride and gliclazide actually have no higher risk of cardiovascular outcomes. So SGLT2 inhibitors, in the last couple of minutes before I hand over to Iqbal, SGLT2 inhibitors are a bit of a wonder drug and have multiple effects on different systems. We were excited in diabetes, and this is probably what Iqbal looked like when he saw the cardiovascular outcome results, and also nephrologists as well. Everyone's got very excited, and they do seem to have effects on literally every organ system. But just a reminder, the effects of SGLT2 inhibitors on CVD risk reduction are derived from studies on secondary prevention, so people who already had evidence of cardiovascular disease. And at present, there have been no studies in using these agents for primary prevention. So actually, when we're considering therapy in the choice of a primary prevention context, what we're really doing is going through that filter that I just showed you. What are our goals of therapy? Are we trying to induce weight loss? Are the side effects acceptable? Plus all of the other considerations that I went through. HbA1c reduction is, of course, a really important part of this. So I would encourage you to read this paper by Mohan et al., which came out last year. And it really nicely summarizes the kind of HbA1c change that we can expect with all of these agents. And by far and away, it looks like semaglutide at the moment has one of the best HbA1c lowering effects. And I'm sure that that's driven not just by insulin production, but also by weight loss. And otherwise, again, you can see the reduction is pretty similar for all agents. What about weight change? So the orange arrows here are weight reduction, the blue ones are weight gain. And you can see sulfonylureas, which again get a lot of bad press, but they're quite effective at reducing HbA1c. You can expect about 2 kilos of weight, whereas the GLP-1 and the SGLT2 inhibitors are pretty good for weight loss. So what do I mention with SGLT2 inhibitors? I mentioned the risk of fungal infections and urinary tract infections. And I just want to finish the last couple of slides on euglycemic ketoacidosis. So this is something that got an MHRA yellow card alert. And in the studies, the initial studies, what was happening is people were giving this drug in the States to people with type 1 diabetes off label. And if you look at Canvas and EMPA-REG, there are actually very few cases of DKA. So this just summarizes the hazard ratios from various studies. And there does appear to be a significantly increased risk in certain groups of individuals. And the people that are at risk are the people that are at risk of DKA. So just a reminder that DKA can actually occur in any type of diabetes. And basically, in the context of stress or catabolic illness or being unwell, you can develop DKA. So that can happen with someone on SGLT2 inhibitors. And I won't go through this, but if anyone's interested in the mechanisms, it does look like the SGLT2 inhibitors also cause retention of ketones as well. So my tips for SGLT2 inhibitors are really to avoid initiation in high-risk groups. For me, those are people that are frail, have a history of ketoacidosis, have a very high HbA1c, because in that context, I'm worried about insulin deficiency, or a very long duration of type 2 diabetes. If I see someone who's had type 2 for 30 odd years and their HbA1c is not quite there, I don't think the SGLT2 inhibitor is going to be right for them. We always counsel about stopping it if they're unwell, and definitely if they present with DKA, they should stop their SGLT2 inhibitor. And in the context of having COVID-19, if people are at home, they should be advised to stop their SGLT2 inhibitor. So although NICE guidelines are a bit vague, the EASD, which is the European Association, and the American Association have tried to put these into a little bit more context, the SGLT2s and the GLP-1 receptor agonists, but they're essentially saying the things that I've gone through in this talk. So that was a rattle through. I think it's an exciting space to work in. There's a real expanding repertoire of drugs, and we really have the potential to personalize treatment. And hopefully I've made it clear that no one-size-fits-all approach with regards to type 2. And we're very happy to be contacted for any advice and referrals. So that was a rattle through. And I'm going to hand back to Iqbal.
Okay, thanks very much. So I think we've got that opinion. I think obviously we share a common ground here. But the one point where I might sort of ask a question at the end is that if you've got a very long-standing type 2 diabetic, they've also got astronomical cardiovascular risk. And that's where the SGLT2 might be handy. So we'll debate that in a minute. So what is it that the cardiologist could be doing? Because diabetes, it's an endocrine disease. What the heck am I sticking my oar in for? Well, the fact is that a lot more outpatients diabetes can be encountered by me probably than the standard endocrinologist. Not a diabetic specialist like Shivani, but she's seeing a pretty complex group, and I'm seeing them at a slightly earlier stage. And so the cardiologists have an opportunity, as do primary care physicians, because you're going to see a lot more diabetes that needs management. You've got the bulk of patients out there. Of course, in patients who have coronary artery disease, one of my specialties, then a lot of them actually have diabetes. And in West London, it's probably even higher because of the Asian population. So there's a lot of it about, and ignore it at our peril. A lot of people in our clinics will have diabetes, so ignore it at our peril. And as Shivani mentioned, that diabetes is a terrible killer. So if you have a heart attack, then you're going to die about 5 years earlier than if you didn't. Actually, if you're Asian, you're probably 10 years older than if you were Caucasian in terms of your cardiovascular risk. If you've had a heart attack and you're diabetic, you can see that pretty much on average, you're going to be losing over a decade. And so whether it's any cardiovascular event, diabetes is a terrible thing. So what's preventing both you as GPs and me as a cardiologist getting more involved? One, the silo mentality that it's just for the diabetic specialist, and we have to get away from that. Even pre-COVID, were we just too busy to deal with it? I think that would be wrong because of the astronomical risk. Is endocrinology better placed? Well, at the specialist end, of course they are, but at the non-specialist end, I think we see more of them and can get experienced in it. And of course, are the treatment algorithms very complicated? Are we difficult? Do we have difficulty discussing side effects? I've trained myself into actually knowing the side effects and making that discussion possible. Just as you remember, you're supposed to ask our cardiovascular patients about impotence and things like that. It's difficult when you first do it, and then it becomes fairly straightforward when you're used to not being embarrassed about it. One thing that I'll mention here, and we're happy to answer questions later, is what about the SGLT2 inhibitors, even if there's no diabetes? Now, this is sexy new news because diuretics, as we know, don't make any difference to long-term outcome. They help your breathing, but they don't make you live longer unless you're dying of heart failure immediately, acutely. Beta blockers, ACE inhibitors, the mineralocorticoid antagonists, and the Entresto, all, of course, make you live longer. But this class of drugs, DAPA, evidence-based and licensed, and EMPA, evidence-based and about to be licensed, are very exciting. But this is in heart failure with a reduced ejection fraction. There are trials coming out at the end of the year in heart failure with a preserved ejection fraction, a group of patients where the cupboard is pretty bare on any prognostic drugs. And of course, on top of that, we'll put in ICDs if the ejection fraction is low, a CRT device, a complex pacemaker, if in fact they've got bundle branch block. And of course, if we can get their LV function better by replumbing them, then that's a real godsend. So just a brief note about DAPA versus EMPA. Well, which one are you supposed to use in heart failure then? Well, the trials are very, very similar. The take-home message is that it was well done. It was against standard therapy. One message from the DAPA trial is that they excluded people who couldn't take DAPA. So they already had a selected population that could tolerate the drug, which is what EMPA did not do. But EMPA decided to exclude a lot of recent cardiovascular disease and therefore almost biased themselves against a good outcome. The outcomes, however, were incredibly similar. So you can see about a 24-25% reduction. And I like numbers needed to treat. And numbers need to treat to reduce heart failure or cardiovascular death was about 20 in both groups. So very similar. Great news. Both of them are 10 milligrams each. So you don't even have to remember complex dosing. And both of them produce very similar primary outcome reduction. So actually, I'm saying it doesn't matter. 10 milligrams of one of those in your heart failure patient may be a good idea, even if they're not diabetic. And those NNTs look pretty impressive, considering that simvastatin, that trial in 1994, 5 years of simvastatin after you'd already had a heart attack, the NNT was 30, and we are thought to be mad if we don't give a heart attack patient simvastatin these days. Ramipril in HOPE was 39, and EMPA in the EMPA-REG study was 39. And remember, that was not a heart failure study. So the heart failure population really does benefit. So what about the mechanisms? I think Shivani's dealt with that, and she's also dealt with which drug. I think Shivani, do you want to come in here and talk about why we think the SGLT2s do the magic that they actually do?
Yeah, sure. I mean, look, at the diabetes conferences, this is hotly debated. Everyone gets really excited. So I think the thing to say is we don't quite understand the mechanism yet, but the key points are actually what Iqbal's got on this slide. So the fact that glucose is being keyed out in a fashion that's independent of insulin seems to be a really important thing here. There's also a lot of visceral adiposity. So if we think about the things that are driving the insulin resistance in people with type 2, a lot of it is visceral fat deposition, which is really an important factor in making someone insulin resistant. So SGLT2 inhibitors, they tend to lose 5% of their visceral adipose tissue, which I'm sure is brilliant. And then the sodium loss, I think, is the key part of the heart effect. So it just seems to be, like I said, this wonder drug.
Okay, and I think on top of that, there is some evidence that it may be doing something in the myocardium as well. It's always about myocardial fibrosis. The hope is that some of it will also affect it. So why it's got such a magic effect when, diuretics don't do it, is still strange, but it works. It's evidence-based. So the summary of the EMPA-REG was pretty much good news all around. So the primary endpoint, which was about cardiovascular, cardiovascular events, was down. Cardiovascular death went down significantly. So that's really amazing. Heart failure went down when it's not actually a heart failure trial. All-cause mortality went down when actually it wasn't designed as an all-cause mortality trial. And kidney function got dramatically less bad. So the worsening nephropathy was good news as well. So hence why cardiologists are sort of falling in love with the SGLT2s. So this was just to show the heart failure data. Remember, this was in 2016, and the heart failure trials had not been done. They've now come out. And remember, 10 of DAPA or 10 of EMPA in your heart failure patient on top of everything else produces a benefit. This was the death of any cause, and you can see the curves keep on separating. So it's not one of those where you stop it after 3 years and think you'll still get the benefit. I think keep on the drug, it'll continue. It's a bit like the statin curves. And this is the kidney function, again, separating out and continuing to separate. So I think in the final stage of this, we're going to get into cases. And so, Rupal, if any questions come up, because I've now I can't see the Q&A because I'm doing the slides. We'll start off with Lisa. And so, Shivani, if you had this lady who is 60, the BMI is 30, she looks Asian to me. So I'm horrified to hear that on your slide, over 28 BMI is obese as an Asian. So luckily I'm just under that. But this lady's over it. So she's overweight. The blood pressure, she's on Ramipril. The LDL is actually not bad. And she's had ACS quite some time ago and no symptoms since. So she's on metformin. The HbA1c is 53. I'll put the choices up for the audience before you start talking to say, what do we think? Is it that she's fine? She's okay. Leave her alone. Go on a diet. Refer her immediately to bariatric surgery. Focus on the sugar with some drugs, or just focus more on the heart and get her LDL down to 1.4. Shivani, what do you think?
So I think about 5 years ago, this lady would have ended up on sulfonylurea, and that would have been very effective at lowering her HbA1c, but it would have modestly increased her weight. And if we think about what's driving her type 2 diabetes here, it appears to be all of the BMI of the 30. She's obviously got evidence of cardiovascular disease here already. And in my opinion, the single best thing that we could do is try to get her to lose weight. So my feeling would probably be to go for a GLP-1 receptor agonist. With regards to bariatric surgery, I think, it's often a personal choice about what they want to, how far they want to go down. Or do they want to have a procedure like that? But so I wouldn't rule that out, because in terms of actually inducing remission of type 2 diabetes and sustainable weight loss, the evidence is probably with a Roux-en-Y gastric bypass. So for me, it'd be interesting to see what everyone else thinks. GLP-1 has got cardiovascular risk reduction. It's very effective at inducing weight loss, and will probably push her diabetes comfortably into the 40s, if not the high 30s, millimole per mole range.
Okay, so I think we probably all agree with that. Rupal, let me know if there are any burning questions, because I can't quite see them at the moment. And it was a bit tongue-in-cheek about bariatric surgery for her. She didn't look that bad to me. Okay, so I think that's pretty clear that we want to focus on the sugar and actually the weight loss because we're in the early phase. So that's really good. Okay, it gets a bit more tricky. So this woman is 80. This is a joint patient of myself and Shivani. Names and pictures have been changed to protect the patient's identity. She's 80. She is dramatically overweight. She's 5 foot and over 100 kilos. She's 42 BMI. She's had a lot happen to her. She's had a TAVI, a transcatheter valve, for her severe aortic stenosis. She's got a pacemaker in. The pacemaker is really useful, better than an iWatch, because it's got a built-in algorithm that fires off if, in fact, you've got atrial fibrillation. So it told her she's got AF, so she's now being anticoagulated. She's got terrible lungs, been on inhalers and steroids for a long time with an FEV1 of 0.6. She's anemic and she's got renal impairment with a creatinine of 186, EGFR of 24. Her sugar, when Shivani saw her, was bad. HbA1c was 75, but the blood pressure was okay, even when we stopped the ARB and the bendoflumethiside because of her chronic kidney disease. So she's on a whole host of pills, including steroids. She's already on insulin. So Mary is quite contrary. What do we do with her? Shivani, what are you going to do with her?
Yeah. So I tell you what I do in this situation. I don't know what other people do. I'd be really interested to hear what other people do. I basically go through the entire repertoire and ask myself, yes or no. So can we give her an SGLT2 inhibitor? No, her EGFR is 24. Can we give her a GLP-1 agonist? You're not allowed to go down to end-stage renal failure, so EGFR less than 15. But a GLP-1 agonist, there's no other contraindicating her. The major thing would be liver enzyme derangement, which she doesn't have. But is GLP-1 therapy at the moment the right treatment for her, given that she's already on insulin and is 80? So she's already on maximal glycoside therapy, so we can't do that. She's already on Lantus, so the real question, and the other options are not really there. So, we can't get, she's off metformin already before that EGFR got down to there, and pioglitazone is no point. So what can we really legitimately do? And so actually what I did was reviewed her blood sugar profiles. And the reason that I went down that route was because she was on steroids. And as we know, prednisolone takes a few hours to get going. So you classically see a rise in blood sugars later on in the afternoon. And what became apparent was that her blood sugars were in the 20s later on in the afternoon, but then coming down to normal in the morning, signifying that she had good insulin production. So what we did with her was review her insulin technique. She was actually not injecting her insulin properly. And I actually switched her insulin to a intermediate acting form, so Humulin M3, which she now takes at lunchtime, and which will address the peak related to the steroids. Is GLP-1 the right option for her? My feeling is probably not. She's 80. You haven't seen her. She's quite frail. She's very breathless. What do we have to gain by significantly losing her weight when she's already requiring insulin? The counter to that is she has evidence of cardiovascular disease, so it might be useful in that way. By changing the insulin, her HbA1c came down to 54. So we'll see what happens over the next few months. When I think, just one point to make about her, what did she want? She wasn't bothered about her HbA1c. She wanted to eat freely. She wanted to eat freely and enjoy her food, which goes against the weight loss. And the thing that will allow her to do that, in my opinion, at that moment in time, was some Humulin M3 with lunch, which will cover her for the whole afternoon and evening. So maybe I'm wrong. Maybe we should go for GLP-1. But, long duration type 2 diabetes, are we going to achieve a good HbA1c reduction? I don't know. There looks like a few people have asked things or not.
So one question is if we had, so not specifically to this, I think the approach here is probably correct. I have twisted her arm again and again to get bariatric surgery. Although she's frail, I think her weight is the biggest problem. And so it's a good time to ask you, Shivani, bariatric surgery with gastric bypass produces amazing weight loss and actually amazing changes in the diabetes status. So I think she would get through bariatric surgery. We've done a lot to her heart. Her heart is strong. Would you actually be considering that if the HbA1c's come down, but she remains a ball and she'll remain breathless while she is a ball and she's not going to stop eating. So what about bariatric surgery for her?
Oh, it's so difficult. And I personally think that having met her, it's about asking what she wants. And she and different 80-year-olds might say something different, but as you know, she's reluctant to have bariatric surgery. And again, at this point, HbA1c reduction and weight reduction, what are we actually achieving? We know that having type 2 diabetes over the age of 75 is actually gives you a survival advantage over people that have a normal HbA1c. So by driving her weight and her HbA1c down, we're meeting our targets, but are we actually achieving anything in terms of benefit here? And so in this, maybe people are more intensive than I am, but in this situation, I go back to what they would like and what we can do to give them that freedom. And for her, that's Humulin M3. Now, I take your point, that's not going to help the weight, but she's worried about her blood sugars, not about losing drastic weight.
Okay, no, I think that's pretty clear. There's one question, there's two questions about the SGLTs we can answer now. One is, if the patient's on SGLTs and come for emergency surgery, is there any precaution that the anaesthetist should be taking there?
Yeah, really good question. So any surgery, even elective surgery, SGLT2 inhibitors should be stopped on the day of surgery. There's good evidence that the euglycemic ketoacidosis can be precipitated even by elective surgery. So that should be stopped on the day of the surgery. And bearing in mind that might need insulin to be initiated to cover depending on what they're on. So those are the sorts of things where you can get in touch with the diabetes team to provide advice on those issues.
Okay, one other question while we're here is that if you just remind us what level of creatinine or EGFR means you don't give an SGLT2 inhibitor.
Oh yeah, so currently you're not supposed to initiate an SGLT2 inhibitor if your EGFR is below 60. If your EGFR drops to below 60 whilst being on an SGLT2 inhibitor, you can continue on it down to an EGFR of 45. Now, given Credence, which is the big study that looked at the effect of canagliflozin on renal outcomes, and then there's been the DAPA one, that I'm sure that's going to be changed. I'm sure the license will lower it probably to about 30 because it is literally the only drug that can improve microalbuminuria and CKD. So I'm eagerly awaiting for that license to change.
That's really great. And actually, the two big heart failure trials, they excluded people who had an EGFR of less than 30. So it seems crackers that then the license is completely different from that. So I think you're right. That will actually change. So I have pushed as hard as I can for bariatric surgery. I really think that would be curing her, but she doesn't want it. And so we've done her heart as much as possible, and Shivani's making good effort to keep her happy. I think you're right. She's 80. I think you're probably right. Keeping her happy is probably better than keeping her alive. So she's making her choices. Okay. So again, the name and the photo has been changed to protect the identity. It's not actually my patient Amitabh, but it's a 67-year-old Asian man who certainly has had a heart attack about 5-6 years ago, had a TIA 2 years ago, has hypertension. Whatever I say to him, he's not stopping smoking. He still likes the cigarette. He's got that lovely, raspy, throaty voice of a smoker. He's got a mild degree of anemia, fatty liver, COPD because he's a smoker. He's had 10 years of diabetes. He was actually previously on a combo tablet given to him by a friend of his who's a doctor. Another friend of his changed him to metformin, which he then stuck on for another 5 years before getting to me and then to Shivani. HbA1c was 76, creatinine 97, giving an EGFR of 69. His lipids are certainly not perfect. We're upscaling his statins and his blood pressure. That's 137/75 on a 24-hour blood pressure monitor, which means about 147/80, so not really good enough in someone who's diabetic. So he's on dual antiplatelets because of his coronary disease and TIA. He's on inhalers, vitamin D, iron, losartan, atenolol. So this tricky customer, and he's a bit grumpy, I have to say at all times. What do we do with him, Shivani?
Well, I mean, we've all got him under us, haven't we? Anyone that looks after people with diabetes. And, in a way, this is great because it's a blank slate for someone like me to just go in and actually look at what the individual wants, what their goals are. And, is it weight loss? Is it, are they willing to make changes on their diet? Are they willing to go down the increased physical activity route? And this man is very centrally obese. So although his BMI is 27, that is just in the 27.7, that's just in the obese category for Asian people. It is very prominently over the abdomen, and that is really driving the insulin resistance here. So we've got a fantastic repertoire of drugs. I never rule out sulfonylureas, although I wouldn't recommend one in him, but I do still use sulfonylureas quite a lot in different patients. But I think we could do anything here. I mean, his EGFR had sort of hovered below 60 and then had bumped up again. So we spoke about SGLT2 inhibitors. Some of the older individuals seem, who are a bit more switched on, are a little bit, I find, worried about SGLT2 inhibitors because they're relatively new therapies. He'd also meet the criteria for a GLP-1 receptor agonist. It's on the borderline of that BMI criteria, but I think, it would be effective in him. It would cause quite a lot of weight loss, and the weight loss is not just going from the central adiposity, it's going from everywhere. So just thinking again about how slightly older people from different ethnic groups perceive their weight, somebody who doesn't necessarily think they're that overweight, they're going to lose fat from everywhere. And again, it's just talking through those sorts of considerations. I certainly don't think he needs insulin. We've got plenty of other things to try. And what have I missed? So sulfonylureas would bump his weight up a little bit, but would get his HbA1c down very effectively. So in him, out of all of them, I'd probably opt for an SGLT2 inhibitor. It would get rid of the glucose in an insulin-independent fashion. It would cause a modest weight reduction and should tackle that HbA1c nicely. The other thing to consider is that in Asian people in particular, for any given weight, they are more likely to have less beta cell function than compared to a white European person of the same body weight. So in terms of escalation of therapy with him, we can go for an SGLT2 inhibitor now. But if that fails, we do have in the back of our minds that they have more of an insulin secretory deficit than a white European person. So I suggested an SGLT2 inhibitor. Of course, did he listen to me, Iqbal?
So he did not, because I'd suggested an SGLT2 inhibitor as well. Actually, he came back with your very detailed letter where you'd gone through all the options with him. And then I have not persuaded him to stop smoking. That's never going to happen. He is now on empagliflozin. And he is on a higher dose of statin. He is now on losartan to get his blood pressure down. Unfortunately, he has also developed angina again, which is hardly surprising, and he is due for an angiogram. And so I think we're getting the diabetes under control. I think his risk factors are coming under control, and we now have to make sure he doesn't drop down dead of his coronary artery disease or another stroke before all of that can take action. Can I ask a question from the audience? And that is I've forgotten the question now. I had it here on the live question. So answered questions. So let me go. No, I think we've already answered the renal function one. Okay, that's fine. So I think he is a difficult customer, and I think it is actually coaxing him in the right direction. And I think independently we pincered him into the right maneuver. I think it was a pincer movement that was required. So this would tell you that if someone got even a little bit unwell, you stop every drug known to man and see what happens next. So how much of that would you actually stop if someone got an acute illness and got a bit dehydrated and their creatinine went up a bit?
It's a good question. I'm going to answer from the diabetes perspective because I'm not a renal specialist, but I think the major one to stop if someone's unwell is the SGLT2 inhibitor. The sulfonylurea, that's when they're going to be unwell, they're going to have stress hypoglycemia. Blood sugars are going to go up. If you stop everything, they're going to completely decompensate. Metformin is also reasonable. I mean, assuming you know what the creatinine is. Certainly in the patients that were coming in with COVID, with AKIs, we were stopping SGLT2 inhibitors and metformin, but restarting the metformin quite quickly.
Okay, I think that's pretty clear. So the SGLT2s, I think I would certainly stop the non-steroidals. I would certainly stop the ARB. And actually, if the EGFR had really fallen, the creatinine was over 200, the metformin in my hands would probably stop permanently. Because I remember that old story about lactic acidosis. I've never seen anyone on metformin having lactic acidosis. That was fenformin. But actually, it's I think it still wouldn't be a good idea for someone with known renal dysfunction to be on metformin. And the ACE inhibitors, I think we can temporarily pause. Stopping those for 24, 48 hours doesn't make any difference to anyone. Okay, great. So I think if we then sort of summarize and then take questions, I'd like to thank Shivani for joining us. She's given us a lot of education. Thank Rupal for actually organizing this and actually filming it so the video is available to us. And Rupal, I'm going to stop sharing and hand over to you because then I will be able to see if there are any final questions as well.
Fantastic. Can I just thank you both very much? It was a really insightful discussion. It's actually great to hear opinions across two different specialties. And while Iqbal sees if there are any more questions, I'd like to also let you know that our endocrinology services are open on the 7th floor at Welbeck. If you have any further questions for either of our panelists from tonight, please feel free to get in touch with me and I can direct you to them. Iqbal, any more questions?
No, the only other one was renal function, which I think we've answered. I think if the creatinine is going over 200, because my brain's not big enough to calculate EGFR the whole time, then I would be very nervous about continuing quite a number of drugs that were on that SADMAN's chart.
I would just add to that. So I think in the context of an acute AKI, I would definitely agree stopping metformin. In more of an outpatient setting where there's a gradual decline and you can see it's heading, the creatinine's going up and up and up. NICE guidelines obviously say below an EGFR of 40, it should be stopped. If it's going up and up and up, I start making plans about stopping it. And it's just worth making the point that if you suddenly stop metformin in someone that's got reasonably good control on, say, 2 or 3 agents, the HbA1c can really shoot up and the diabetes can completely decompensate. So it just needs some thought when you see the HbA1c climbing. And I usually stop it at around 150 in an outpatient setting.
That's really good. And I think I would probably do the final thing to, as an excellent comment from one of the audience that says that, if you have that very difficult patient, then finding a GP who's not a friend to give a more stern lecture might work out. But my only caveat to that is that I'm no friend of his and neither is Shivani, and we haven't managed to do it. So it may be that a GP would be able to persuade him who's not a friend, but I suspect that there are some recidivists that would never be successfully thought through their condition. It is the way life is. But with that, I'd like to say thank you, everyone, and thanks for joining. Thanks for all the questions. That makes it much more interactive. Shivani, you were brilliant. Thank you so much for all the comments, and I've learned a lot. And Rupal, final thank you to you, of course, for organising all of this.
And thanks, Iqbal. Thanks for chairing, and brilliant.
Thank you both. Have a fantastic evening, everyone.